Respected Chairman and dear friends, a very good morning. So I'll be talking about primary repair in an acute dislocation, and this is completely in sync with the presidential theme, which is adapt and evolve. So how has this treatment evolved? You've heard earlier that shoulder is inherently unstable, accounts for the most unstable joint, and this is purely because it's mobility which is more at the cost of stability. So when this happens, what typically restores or destroys is the static stabilizers or the so-called hammock. And if you look at the pathoanatomy, when the dislocation does take place, it results in the essential lesions, which is the Bankart and the Hill Sachs, where a Bankart is the capsulolabral tear at the level of the glenoid, versus the Hill Sachs, which is a posterolateral impression fracture in the humeral head. Your classic MRI findings is this is what you would see in a primary dislocator, and I'll discuss about this in detail. So why do you want to do surgery when you're thinking about a primary dislocator? Now the first thing is what you're going to do is restore normal anatomy. You're not waiting for anatomy to get destroyed. Second thing is it's a selective correction of the abnormality. You're trying to restore your normal range of movement without any loss of external rotation. And lastly, the so-called therapeutic benefits of retaining proprioception. So then who gets this surgery? It would be preposterous to say that each person who undergoes a primary shoulder dislocation would land up with a surgery. Because I think Hovelius has clearly shown that then nearly up to 50% of patients are going to get additional surgeries, which is not called for. So there is a select group that we are looking at, primarily males who are younger in age group, that is less than 25 years, who are engaging themselves in high demand physical activity, and if there are associated pathologies like a greater tuberosity fracture or a glenoid rim avulsion fracture which is displaced. Now, we know that it's all about the hammock concept. So if I were to simplify this, this is how the hammock looks like. And you can have the hammock attached at the humeral side and at the scapular side. Now the destruction of the hammock can happen at multiple sites. But what typically happens in a primary dislocator is your Bankart tear. And this is how it would look on an arthroscopy in a primary dislocator. As you run along the anterior-inferior labrum, you will see that this is the anterior band of IGHL, and you can see that there is no labrum right here, and this is a robust labrum looking here. And that's a small Hill Sachs. Now the same thing, when you're looking at it from the anterior-superior portal, you can see how the labrum is well reduced, or rather is quite robust and is moved out of its position. Now this is a patient who is just one more dislocation ahead. This is the second time dislocator. And you can see the amount of cartilage damage, and you can see the quality of labrum, and which is moved up on the neck of the glenoid. So what we are trying to emphasize here is that if you're going to wait for consequent dislocations to happen, there is going to be further labral damage, further cartilage damage. And this is important from the long-term prognosis perspective. So handle the small issues when you can do that. A stitch in time saves 9. So when you can restore anatomy, you don't want to wait till the anatomy is completely destroyed. Now that we've understood this, then which type of surgery are we looking at? So if you run back into literature, before 1990s, there was hardly any talk of doing a primary surgery in an acute dislocation. Rowe had shown in 1956 that open Bankart repair is probably the gold standard. But it was in 1999 that a group of Swedish surgeons showed that simply an arthroscopic lavage compared to non-operative treatment resulted in better outcomes. Now, they could not explain the mechanism, but one of the thought processes was that once you evacuate the hematoma, it allows for better coaptation of the labrum and allows for better healing. At the same time, arthroscopic transglenoid repairs was spoken about, where using a Caspari punch and drill holes through the glenoid, you are going to repair the labrum to its native position. And what the authors showed that in patients younger than 30 years, the redislocation rates was substantially reduced and the range of motion was not affected. It was not before 2002, and this is probably the earliest randomized controlled trials which spoke about what we do now. That means doing arthroscopic stabilization with anchors. And they spoke in this report that in patients younger than 25 years age, with a known high demand activity, you can restore their normal anatomy. And that would reduce the recurrence rates. If you were to further go into literature and look at the Cochrane review in 2004, because we don't have something after that, the limited evidence, even at that point of time, it supports surgery in the younger age group, usually the male patients who are engaging themselves in high demand physical activity. So if we don't do repairs and if we allow these patients to keep redislocating, I think this is a paper which each one of us should read. This is from Hovelius, where he's shown the association of cuff arthropathy at 25, or rather instability arthropathy at 25 years, and it clearly mentions that arthroscopy is associated with shoulder dislocation. And it's obvious, it's common sense, because you are allowing the anatomy to get destroyed, you're allowing the cartilage to get destroyed. So if I can restore the normal anatomy, I can allow my patient a full range of movement and no limitation, there is no reason why I shouldn't contemplate a primary repair, especially in that select population. So if I were to give you 5 take-home messages, treatment of first-time dislocators is still controversial according to literature. Surgical intervention, think about it in select population. When you're considering restoration, it's considering surgery, it's restoration of normal anatomy is what you're looking at. But my age group that I'm looking at is a less than 25-year-old male patient engaging himself in high demand activities. Thank you.